So I'm going to go ahead and get started, even though I know people are still joining. But Dr. Cao is a program director of data science at the New York-Presbyterian Hospital. She received her PhD from the University of Virginia and master's and bachelor's degrees from Southeast University in China, all in biomedical engineering. After PhD studies, she was a junior faculty member at Vanderbilt University Medical Center and a senior research scientist at Philips Research North America, and also a data scientist at Xerox / Conduent before joining NYP. Her research interest focuses on building creative and impactful data science solutions to improve frontline patient care and back office finance efficiencies. Besides 14 publications and 11 patents, she's received the ASPEN Abstract of Distinction Award for novel NLP approaches to predicting malnutrition in 2023. And without further ado, I'll let you take it away. Thank you so much for being here.
Thank you for the introduction, Pooja, and also the opportunity to present some of the work done at NYP here in this forum. I'm actually a big fan of this DBMI seminar. I attended lots of the seminars and try to learn and interact with lots of the students and speakers. And after a couple of years, I felt like obliged to maybe share some of the work we've done at NYP and also open for collaboration and seek for feedback of our work. And so our work is a little bit different angle compared to maybe many of the speakers or presenters in the past, is more focused on the R&D versus on research. But I can walk through this process and perhaps we can have an interesting discussion. So the title is that we've done some healthcare transformation using machine learning, artificial intelligence. And here I'm specifically talking about use case in the monitoring AI screening tool. And it's collaboration with many brilliant data scientists and also the nutritionists and the multiple IT teams, etc. So you'll see their work shortly. Okay, so first is that what actually intrigued me when I joined NYP is about the prospect of healthcare transformation using digital health. So this concept is relatively new. I think maybe 5 or 6 years old of this transformation of healthcare. The concept was trying to use the digital technologies of recent development in artificial intelligence, especially, and big data of Internet of Things, as well as the cloud computing technologies, and using them to develop these innovative solutions. And in particular, in NYP, we tackle 2 areas. One is automation, another one is intelligence, some kind of intelligence. And ultimately, the goal is to benefit the end users, for example, patients, providers, and the back office administrators. Working in the hospital, actually, this is the first time I was had some kind of involvement or collaboration with the back-end office administrators, financial teams, and etc., like clinical operations. And it was a fascinating actually experience for me. So I'll share a little bit more later, but let me continue. So before I go on with the malnutrition, I would like to share with a little bit the use cases of this healthcare digital transformation. And we are involved, as I said, we involve 2 processes. One is the automation, another one is AI. So we have developed, not me, but our team has developed lots of we call it robotic automation process, RPA process. And so it can be applied to the financial clinical operation aspect. So I just, there are lots of applications where I think the team has developed maybe 100 of different processes. And I just used one example here. For example, the last one is the invoice processing. Essentially, what it does is that the hospitals, it's a big thing, right? It's a big organization. It buys lots of stuff, for the patient's drugs and the supplies, etc. And so every purchase would have an invoice. An invoice usually comes in with as a PDF file sent to us. But then in order for the supply chain to document or inventory all these things, the data has to be extracted from these invoices. For example, when this purchased, what item, how much cost, etc., right? And usually, previously it was done manually. And we just leverage this process, automatic process, so that we can, according to like RCR, like the read through these documents of the PDF files and extract information and put them into a spreadsheet or database automatically, rather than just doing it manually, which is subject to error, human errors, and also very tedious. So the sense of this automation process is very like to replace the repetitive and tedious manual work with some bot doing the same thing more fast and potentially even more accurate. So that's the low-hanging fruit of the AI or transformation, if you wish. Another thing we have been dealt with is, maybe you are more familiar with using machine learning to do lots of analytics, predictive or prescriptive, or like computer vision or remote monitoring, or that kind of things. Probably you know better than me. So, so this is essentially what NYP has been involved in 2 areas. I'd like to touch base a little bit about the difference or the similarities between research and R&D. In case some students probably is thinking their career that, okay, so after I graduate, got my PhD, where should I go? Like, what's the differences between research and R&D? Because I have been in the corporate research, academic research, corporate research, and then R&D like through the whole my career. So I can share a little bit of my what I've learned along the journey. So my understanding of the research is mostly about trying to discover novel knowledge, novel insights, or develop, design novel approaches to solve some problem. And this problem could be general, not necessarily a specific problem. Essentially, when I say general, is I can apply to different, areas, different applications. For example, machine learning, right? So its approach, it can apply to healthcare or financial or supply chain. It can be everywhere, right? So that's approach. And on the other hand, R&D is about utilizing the existing approaches, existing knowledge, but develop new applications. It can be new to the world or it can be new to the organization. And the end product is a product. At the end, the final output is a product versus a research probably is a paper or a method or some kind of algorithm. And there are some differences and similarities in the characteristics part is that usually for research, you have to be really exact. You have to be very careful and very rigorous. Make sure that you didn't, lose anything or like be some like loophole or something. And also you have to be like investigated in a way that is meticulous in a sense. On the other hand, R&D is more focusing on that. Okay, so I have got this mechanism or the algorithm work, and as long as the accuracy or the model performance meets my original criteria or my benchmark, then we're ready to go. We can do, even if they're better, like you can develop more models or better models, but I don't care. I'm going to deploy it. And so the challenge here is for R&D is actually you want to make sure that your algorithm, your model can be applied across different systems or different hospitals or different units. So I actually got a very deep understanding on this when I work on Xerox. When we developed a product, it turned out that different hospitals have so many different nuances or different situations that we keep like updating our versions to make sure we cover their unique kind of each individual unique aspects. And there's a lot of the iterations, if you wish. And because of that, there is some uncertainty related to it, because it may not work for all hospitals. And that sounds like not a success, right? And also because of we have to deal with all these things, we have to be creative to see if we can find a common solution to all different scenarios and different hospitals. So that is the challenge, different challenge than the research challenge. The research, for example, as a PhD student, right, you have to find something new to the world and nobody has done before or like whatever, right? But here is like, you want to make sure that your model can be applied across everywhere. So that's the 2 challenges, that's 2 differences. And here in this application in particular, we are more like R&D part. So we do a reasonably good model performance, we move on to deploy. I'm going to share with you a little bit like a quick introduction of some of the other data science, ongoing data science projects we are doing right now. As I said, for financial, right, there's clinical and financial aspects. For financial, the first project actually we did is the clinical PO assignment optimization project, where back actually right after I got hired, the finance team reached out to us about a particular problem about the clinical PO success rate has been going down, and they want to see if there's an algorithm or something to help them to bend the curve. So here, the innovation creative kick in. We translate this business problem to a mathematical problem we can solve, which is we try to optimize the clinical PO assignment, which not non-obvious way to do actually this bend curve. And it turned out it's been very successful. We harvested like more than $10 million a year since production in 2018. And currently we are in the continuous improvement stage, because now we have Epic and things have changed, nurses have changed, etc. So we are now in a second round of this optimization development. And the second project is the pre-billing outpatient conversion project, also started in 2018, where actually NYP has a very special situation because NYP does not have the observation unit. So for patients who are expected to stay overnight only, should be considered as outpatient, but NYP it's considered as inpatient. So what we have to do is that we have to convert them back to outpatient instead of inpatient. So, but on the other hand, because nurses are very weary about this regulation, government regulation, so they sometimes been overly conservative and put some patients could have been inpatient, they put them as outpatient, and then NYP lost revenue essentially. So this is a project trying to make it like optimal kind of conversion of outpatient. So these are financial projects, mostly about using like machine learning, artificial intelligence algorithms, etc., to improve the financial outcome. And for currently, the clinical project is a monitoring project, and particularly I'm going to talk about the screening tool. And in the meantime, we have done a little bit about the NLP part using attention model, try to improve the model performance. And because of that, it's like a research project. And actually, we collaborate with Columbia Business School, and Sharon was the one actually helped us develop this tool. So having said all this, now we are going to talk about this monitoring screening tool, which I call it MAST. And so first, like, what is malnutrition? So by definition, malnutrition could be under or over nutrition. And the result is that the body composition, essentially you lose body weight, lose body mass if it's under nutrition, and you lose function, like physical function. And this is a definition, right? But in reality, you have to come up with some more concrete criteria by this GLIM, the Global Leadership Initiative on Malnutrition, where they say on the top is the phenotypic related criteria, and the bottom is the etiological criteria. So at least one of them have to be met in each criteria. Then the patient is kind of qualified to be a malnutrition. And you can see this is mostly about the weight loss, or this essentially BMI or inflammation or food intake. If you're interested in the underlying mechanism about how inflammation kicks in or related to malnutrition, I'm happy to talk about offline, or if you have questions, let me know. So then why monitoring is important? First, it turned out surprisingly monitoring is very common among inpatients in hospitals in the United States. It covers, depends on the patient population. The literature covers around like 10 to 60% of the patients who are in the hospitals as an inpatient, they are malnourished. Second one is that malnutrition actually have been found to be associated with many adverse medical outcomes, such as longer length of stay, longer ICU stay. In the right hand is like for critically ill patients, ICU patients, and increased mortality, like higher rate of readmission, and all these like mortality, all these kind of bad outcomes associated with malnutrition. And third is that CMS have been set up this global malnutrition competency score to be included as a reporting for quality for hospitals, and everybody has to do that starting from 2023 and report this malnutrition status essentially. So as a result, the ASPEN, which is the American Association Society of Parental Enteral Nutrition, established a clinical guideline saying that for adults, we have to have 3 steps. One is screening, second one assessment, third intervention to care these patients who are malnourished. And shortly after, a random clinical trial has found the screening of malnutrition and early intervention for some patients actually improved their outcome. And this is a joint commission. Joint commission is an organization for accredited hospitals, and also make sure that the hospitals have meet the regulatory criteria about this, especially safety and quality of care. And so they require the hospitals to conduct the malnutrition screening or assessment within 24 hours after admission. So that's actually a very high expectation from the very busy nurses and clinicians. So here's the pathway for nutrition care. So at admission, within 24 hours, every patient are supposed to be screened for malnutrition status. And if their status is say actually they're not at risk, then after 7 days or 3 days, they would re-screen again. On the other hand, if they are identified at risk, then the dietitians are required to assess these patients within 24 hours of this at-risk identification. So it turned out there are numerous malnutrition screen tools. And this is a investigation done by the Academia of Nutrition and Dietetic Society, where they, validated multiple, kind of screening tools. And it turned out they identified MST, stands for Malnutrition Screening Tool, as maybe the top tool or more like relatively good tool among all these tools, as a recommended screening tool. And that is what is currently implemented at NYP. So this is the MST. So essentially, the nurses would go to the patient's bed and ask them these few questions. Have you loosened weight? And how much have you lost? And have you, not eating well because you don't have appetite? And then they have scores based on these answers. And if the score is higher, 2 or higher, then it's recorded as positive as a high risk, and they're supposed to be assessed by dietitians right away. Back in 2019, at Cornell Nutrition Department, they have partnered with a vendor who the initiative is called Malnutrition Quality Improvement Initiative. And that vendor helped them to identify that this, let's say, goes through this screening, assessment, care, the whole care process. And actually they identify the screening is there needs, could be, could use some improvement, because it does not done in a complete, not everybody is completed the screening, and it's not timed, it's not like within 24 hours or something. So as you can see, because of this manual, the nature of manual, right? So the data is relied on the patient self-reported data. So patients, oh yeah, I lost weight, or I don't, like it's kind of a pretty, could be subject to not accurate, and not always available. If a nurse goes to the bed of the patient and the patient is sleeping, then it cannot be conducted, right? And as everybody knows, the manual, this nurse is extremely busy. So the manual screen is not only low efficiency, but also is extra work for them, and they have suffer from more risk of burnout. So that's why the department come to us, reach out to say, hey, is it possible we can do an automatic AI tool to do the screening, to replace the nurses, which, as you know, like more frequent. and the requirement is at least as accurate as the nurses. So when the model, essentially when the tool would be replaced these screening tools, and instead it would be screened by the tool of this AI screening, and then surface the positive cases to this full assessment. So that was essentially the target. So in order to fulfill this task, we have gone and are going actually 4 different phases. Phase 1 is the model development using Cornell data. And phase 2 is that you used all NYP data for model 2. And then we are in the process and wrapping up about Epic integration. And then we're going to monitor and continue development and improvement. And also we're going to see if there's any kind of iteration needed. So the first is the phase 1 is the model 1.1 development and validation. We're going through model development, cross-validation, and also we developed a model deployment pipeline in order to do a live testing, which is a prospect testing on SCM data, because at the time we were on SCM, and then we tried again in Epic. And also we try to understand, okay, so what variables are important, how much impact they are. We also did some model bias assessment. So you can see that the model development part is only 1 bullet point, and the rest are all testings and check-in and everything. Those are more like time-consuming part. So I'm going to quickly go over this model development. So this is retrospective. We started in 2019. So we collected 4 years of data for Cornell patients, adults, and length of stay has at least 24 hours. And they are all screened by nurses because we wanted to compare our model performance with the nurse screen. And data is mostly ADT data, let's say service, hospital service, admission type, admission source, and the BMI and the vital signs, and a lot of the lab results. So these are the data we have. And after we got this data, we did lots of the pre-processing, and we cut the data into 3 batches. On the left-hand side is the development, right? So it's like training data and historical testing. On the right-hand side, we try to mimic the actual model running. So we call it temporal testing. Is so that it's more it's more when we really implement it, we would expect performance look like. So there are lots of details here, but I'm going to skip this because you are probably familiar with this process anyway. And what we have done probably different from a normal research project is that we started with the AutoML in order to expedite our development process. So AutoML actually is a process to, in this particular case, we used the TPOT. TPOT stands for, I think, it's tree-based pipeline optimization tool, something like that. So this essentially is a tool to help us to do the data processing, feature selection, and model selection, and also the hyperparameter optimization. And after we done this model search, this tool will give us the Python code of all these processes, so that we've already got this pipeline actually kind of like half-baked, and then we just tweak a little bit to our data. And it turned out that the TPOT identified extra trees as the best model among 7-8 different models, like including random forest, regression, SVM, IBD, nearest neighbor, or like a number of commonly used neural network commonly used classifiers. And extra trees is less actually commonly used compared to random forest. So the idea extra trees is instead of similar to random forest, it's built out of trees, but similar to different from random forest is that when you build random forest, you select data points by let's say, so for example, if you have 300 data points, right, you select 2/3 of them, so you get 200 data points, but you've got all the features. Extra trees is that you have 300 data points, you have let's say 100 features. It would select, let's say, 100 features and 300 data points to build a tree. So every time it randomly selected a few features, but include all the patient data to get this tree. My speculation that this method is slightly better than first is because we have lots of the features in our feature engineering part, which are highly correlated. I'll show you a little bit later, but they are highly correlated. I think that's why perhaps feature selection part becomes like interesting, kind of addition to compared to the reinforced. So this is the cross-validation results. This right-hand side is RC curve, and this part is where the performance for the nurses, and this is for the same false positive rate, what would be our sensitivity is for our model, and the RC is 0.86, good enough for us. And likewise, this is precision recall curve. Similarly, that when this recall is around 47% at the same time, and in the meantime, then the precision is like 879 compared, like 10% more compared to nurse screen. So it looks like our tool is better than nurse. And as I showed before, we also did some, we call it like stream testing or temporal testing. This is a result from that. And because of this different setup of the data, I can give you more detail, but so we have a much smaller, a lower monitoring rate, is only 3%. And because of that, our performance is kind of different. And in particular, you can see the precision is really low. It's like less than 10% because of only 3% incidence rate. So I put an arrow here because this is something that we are interested to do to try to see if there's a way we can improve upon. And if anybody's interested to tackle this low incidence rate, low precision problem, and I will be very happy to talk to you. But again, you can see our model performance sensitivity when specificity is fixed, sensitivity is a little bit higher and accuracy is slightly higher. So at least we are as good, if not better, than nurse screening for this temporal testing. In order to do a live testing, prospect testing, we have to develop a pipeline because we want to do it automatically. So this is a pipeline we developed, is that every day in the morning at 7 a.m., the MR data extracted automatically and pre-processed through a chunk of Python code and generate this monitoring risk score. And this risk score we outputted as attachment to send to the dietitians. RD stands for dietitians. And then dietitian received the email at 8:30, and they will review and assess the patients, depends on if the score is high or not. So this is a pipeline we have developed. Everything is done automatically. We do not have to monitor or do not have to, intervene at all. I guess this is also part of the automation. And this is the live test results for some selected units at Cornell. When the specificity is selected at this 0.85, you can see our sensitivity is almost like 19% more better than nurse, and precision is also double digits better than the nurses. And this tool is able to identify many more monitored patients compared to nurses. So again, this tool is better than nurses. And we wanted to understand which variables are important and how much they contribute. So again, we used the off-the-shelf hierarchical clustering to essentially identify the correlated features. So I arbitrarily selected a threshold here, and then these are the, for example, these are the three variables, which is the red blood count, hemoglobin, are kind of highly correlated to each other. And so when we do this variable importance, we put them as groups, as I show you here. So we would put them as groups here. So this is a permutation analysis saying that, okay, if I remove these variables, how much reduction of the RC would occur? Because they are correlated, so we have to remove them together. Otherwise, it can be adding noise, right? So that's how we did it. So we removed these two as they are highly correlated, and then it turns out RC can drop like more than 10 points for both historical and temporal testing data. And these are the top ones that have a big impact, relatively big impact to the performance. And another thing we tried is that we used the explainable boosting machine EBM, which developed by actually intern from Cornell University with Microsoft Research back in 2012, back in 2011-12. And so they develop algorithms to, they call it a glass model, where they kind of know they wanted to achieve a reasonably or equivalently good performance, but in the meantime, they can have some explanation behind these model results. So here's some results. This is the BMI. So when the BMI is low, actually you can see when BMI is low, like maybe less than 25 or something, less than 22 or something, the risk of malnutrition is increased. When positive, it's increased risk. But if their BMI it becomes larger, their risk decreases. But interestingly, there's a sweet point, essentially that after the patient, the BMI is increased like 40 or something, really obese patients actually, their risk is even slightly higher than they were before. So this is something that like when the clinicians saw this, they said, wow, this is interesting because it's like giving you a very detailed explanation of how individual value of BMI impact the malnutrition. Similar for age, it's a story already. Essentially, after a patient passes 40, already they are at high risk, kind of start high risk. And then after they are 65, they are at the highest risk here. Interestingly, when their age passes 90 something, 92 or something, their risk goes down a little bit. I call it man-made changes because the 65, the 40, or the 90, etc., are all kind of artificially defined by people. That's why there's a cutoff like this. So when we see this, we find this is like very, very, kind of interesting. We have drawn this diagram, these plots for many P parameters, and they are all very interesting revealing. These are just two examples here. So next is the after model 1 development, right? This evaluation and assessment. And then we developed model 2.0, and we did live testing this year for all patients and all across NYP. I'm not going to show the results because this results essentially is similar and essentially saying that the model results is also still better than the nurses. So we go ahead with this epic integration. And as I showed you before, then when we did this validation, we developed a pipeline which is on-prem, which is in the local machine. So now what we're trying to do is that we're going to leverage Azure, and also we're going to send the model results to the dietitians automatically in Epic through Fire. So this is what I'm doing right now. And so this Epic integration, it's a process, I have to say. It involves lots of the technologies we have to pick up, for example, about Kubernetes, about DevOps, about how to create images in containers, and how to log the files in application sites, and how to do the monitoring of the testing. Like this is a very big process. After we do that, we say, okay, so now we got the data model results. Then we have to send the results to Epic. So there is a Fire, and then there's also a process about how to register your applications, how to get authorizations, authentications, etc., etc. And so this is a teamwork across multiple teams about cloud engineering, data science team for sure, and Epic teams, etc., in order to make this work. So now, as I said, that we are planning to replace nurse screening results. And so we're going to nurse screening. So we are going to replace this, and then we're going to send the results to nurse dietitians. And so we aim to save nurses time, and it would have a potentially minimal impact on the existing workflow. And also we expect it to be improving these dietitians' efficiency. Interestingly, is that when we say improve dietitian efficiency, we have come across some challenges, because how would you define efficiency? So this is still something we're working on, and we're going to do the evaluation. Essentially, after this integration, we're doing the evaluation, do the monitoring, and continuous improvement of this process. And in the meantime, there are some other research questions coming up, and we are open to collaboration for these research questions. For example, as I said, that we did some NLP, and one question we come up with in this NLP, potentially we can further improve our patient outcome result, is that we found some of the terminologies are not standardized. And under the context of the nutrition, some terms could be equivalent, which may not be equivalent for other domain. So we are in the process of trying to normalize the standardized term for the malnutrition related terminologies. So finally, the take-home messages, there are several. First is that healthcare transformation is essentially changing the way how we deliver care, how technology interact with people, with the providers, with doctors, with back-end office administrators. And during the process, there's two areas, which is research and R&D we can attach ourselves to. And in this particular case, we are doing lots of research, the R&D part. And the newest case is a malnutrition AI screening tool that we developed as to essentially bring this tool to the world, making real impact of these clinicians. And they really like our tools when do our lab testing. They really wanted it integrated and to help them expedite, and as well as to keep their workflow, kind of still flow. So in the future, I think we would expand toward beyond screening. We wanted to do this initial. For example, we want to see if there is a way, after we identify malnutrition, right? Is there a way to know which patient would be responding to malnutrition care, which patient would not, and how they would respond, and how we can create an optimized treatment pathway for these patients. So there are lots of the research questions in future to come up with. So this is essentially a collaboration with multiple teams, and a lot of the data scientists and the clinical teams are involved, and so it's a journey. So all right, thank you. That's all my presentation. I'm now I'm happy to answer any questions if you have.
Thank you so much. I see we already have one question in the chat from Abby, which I can read out loud. So she says, thank you for your talk. I'm wondering if you can touch more on some of the challenges with EPIC integration of the model. What are some of the benefits of EPIC integration for dietitians and clinicians?
Yeah, that's a very good question. Okay, so first, for EPIC integration, the first challenge we have come across is that EPIC requires, let's say, in the authorization. So for example, if I log in with my CVID and password, right? If I log in, it will require me to re-authenticate every hour. Essentially, it's for us, we wanted to have this automatically running day in and day out, right? Every day it's run automatically. But if it has to be done manually every day, then it's a kind of a job for us, right? So we have spent a lot of time trying to figure out if we can do this automatically. So that is something we figure out. There's actually something called refresh token. Eventually, after a long exploration, we found there's something called refresh token that we can utilize to do that. So we're in the process to leverage that technology. So that's one aspect. Another aspect about the challenges I can foresee is that so for malnutrition projects specifically, some patients actually are already discharged from the hospital. However, from the data I collected in the database, the patient is still as if they are still inpatient. So if I send these patients to EMR, they will give me there say, you know what, the patient not there, right? And then because the number of these patients are pretty large, so you have to make sure that you check them, make sure that they are actually discharged before you actually really say yes, release them, because you do not know if it's because of the communication error or it's because the patient is discharged. So these are kind of a very realistic real world problems you can come across. So in benefits integration, okay, so the benefits is that the dietitians, so their workflow is that every day they come to the office, let's say at 8 a.m., they will look at their patients and to see if the patient have been screened by nurses and if the screen results is positive or not. So now if we integrate this tool to Epic, the result, the screen result was shown by the AI tool instead of nurse's screen. So they rely on our tool to kick their job to say, okay, which patient I should see today. So this is why they actually, it's like they are really relied on our tool right now to essentially tell them which patient is at high risk you should assess. So that's why they really love our tool, and you know, and also we would also show the reasons, some of the reasons why this patient at high risk. For example, maybe albumin is really low, or the patient hemoglobin is really low, like some, you know, key risk factors shown aside as like if you hover your mouse, show there, and you can see that why the reason, and then you can make a decision, say, oh yeah, I really need to see this patient or not. They have this another opportunity to make a decision for assessment or not.
Mm-hmm. Awesome. I see Chris has his hand up.
Yeah, thank you so much for this talk. It was really interesting to see some of the considerations that came up with deploying these, some of the clinical AI models we're familiar with in practice. My question is maybe a little bit along the same lines, but I was interested in hearing a little bit more about some of the considerations that come with surveillance and monitoring post-deployment. I think kind of from the perspective of methods or model development, there's a little bit more of a growing realization that we need to be considering some issues with like degradation of performance or fairness that come as a result of changes in underlying populations. But I was curious if there were any other issues from the perspective of R&D or maybe administration that aren't as visible.
Yeah, absolutely. Thank you for the question. Actually, I was about to touch it, and I thought maybe too much. So, okay, so actually, for the before we were allowed to deploy this model, we did a very rigorous model assessment, bioassessment, and we found that actually there are a small patient population whose model performance is worse than the rest. And then so what I did is that I used the causal inference to essentially using the propensity score to match the patients, like using all the variables, like they match, except this particular variable, that they have different performance on, and to see if their performance is equivalent or not. And it turned out that after I did that match, the performance is equivalent. So that meaning that that particular socioeconomic data point or this variable is actually not a contributing factor. It's the underlying the other factors, which is kind of represented by this economic factor, was the key to you know the performance difference. And this is before deployment. And after deployment, we are planning. First is that we want to see what are the metrics we are going to monitor. So in real practice, the problem is very complex. First, diagnosis and malnutrition. So everybody wants a gold standard. And unfortunately, that's not necessarily always the case. In our situation, for example, we found that the dietitian's diagnosis rate in certain hospitals in our NIP actually decreases over time. And that is even after we adjusted the patient population using causal inference, adjusted all these like risk factors, all these ADT data, all these demographic information, everything, and still that trend like going down is still there. And so we talked to the clinicians, and it turned out that they but they tweaked slightly of their diagnosis towards some emphasis. And that's a realization of myself to say, medicine is an art. It's not like you have hard rules. You say you meet this, and you this. Otherwise, if that's the case, you do not need a clinician, right? That's already a tool. So that's why that's why I'm saying that first I said the evaluation of the efficiency or of efficacy of this model is tricky. It's very tricky. right? This is second thing. The third thing, it's a good point that the patient population can change. So for example, we've already seen COVID patients. Previously, we have lots of COVID patients. That's why we stopped this tool development for a while until COVID is gone. Because when patient is COVID, they are not assessed by dietitians for malnutrition, most likely. And so we do not have data. And also, these COVID patients would have a different malnutrition pattern or profile than the other patients. So for this kind of dramatic change of patient population, then obviously the tool would potentially break. This is about patient population change. And fourth, the model, itself could be, kind of, as I said, that could have more better model coming or more measurement coming. And also the feature can be different. For example, I give you my life experience myself, which is that when I was at Philips, we developed a tool called a respiratory instability tool. Essentially, if the patient, like the shortness of breath goes up, like they have some, I don't remember exactly what are they, but I remember there's like the airway pressure, some of the airway pressures. If they are low, then they tend to be, respiratory unstable or unstable or something like that. And we found that, we published that, and then the doctors say, hey, okay, so now let's try to, increase this airway pressure, right? And then, so when we evaluated our model, we found that everybody's air pressure becomes much more low than our previous training data. So then our model doesn't work anymore. So like, because of the clinical practice changes, the model doesn't work. So it's like, okay, so we have to retrain our model. So at that time, I felt like, oh my God, it's endless. Because now you train a model and now changes in practice. You have to change another model and train again because they learn from your model. And said, oh, wow, so we can have endless continuous development of this, kind of. But in the meantime, the good news is that because of these new insights, the new practice models, tools, etc., we can see the progression of the clinical practice, and then patient outcome increase, right? So we may not be able to really quantify our tools efficacy very rigorously or very precisely, but we are happy to see that we are contributing to this community along the way. So that is one challenge for us, because if we're talking about ROI, then it's a little bit harder for us to justify ROI in this situation. I hope that answered your question. A very long answer.
Yes, thank you very much.
Sure, thank you for your question. Is there any other questions? Let me see if there's anything on chat.
Yeah, sorry, I was just looking also to see if anybody had any other questions. I don't see anything in the chat, but if anyone wants to raise their hand.
I guess I didn't put my contact information here, but you can search me, and then you will find my, I think Pooja has my email address, and then you can feel to reach out to me offline if you have any questions. And I'm always, actually, I was a teacher before I joined, I came to the States. So I'm always very happy to communicate with the students and learn from them. And they are young minds, and also they are very active, thought. And I was always enjoy that very much. So please feel free to reach out before I reach out to you.
Awesome. I'm more than happy to share your email with anyone who's willing, as long as that's okay. So that sounds great. And thank you so much. Okay, in that case, maybe we can wrap seminar a couple minutes early. But let's just end with a final round of applause. Thank you so much for this great talk. Super interesting to see this on the deployment side. So very, very interesting. And thank you so much for sharing. I know that you're at seminars all the time, so we so appreciate you as a part of this community, sharing what you're working on.
Thank you. Thank you all for this opportunity as well.